My name is Shahrouh Sharif, who I currently work at CSF, Community Systems Foundation, in partnership with UNICEF to develop the Equitable Impact Sensitive tool, EQUIST. This session will involve a short demonstration of the tool, also going into detail on the background of the tool and some specifics of how the tool's been used as well, and following the structure of EQUIST and how it's been used in country and what sort of outputs are expected to be developed from this tool. I'll also talk a little bit about the Narrowing the Gaps publication, which is a push on equity and sort of providing the case for equity, which is Igor has covered, I think, much of the ground in terms of the background of EQUIST and how equity was made as a big, strong case for investments. So, starting with the Sustainable Development Goals, the SDGs, there were 193 UN member states that had adopted this agenda, the 2030 Agenda for SDGs, in September 2015, and this was following the MDGs and the setting of targets and specific goals globally, country by country, to ensure that specific targets are reached across the spectrum of different sectors, one of which, what we'll mainly be looking at through EQUIST, is SDG Goal 3, so it's looking at good health and well-being. And it's following this premise that no one will be left behind. So to try and ensure in an equitable sense that everyone is receiving acceptable levels of coverage, of health coverage, is receiving health care and necessary care in general, and health services to ensure that their livelihoods are improved and that deaths are reduced, mortality is addressed, and this sort of message that leave no one behind. So SDG 3 is, again, what EQUIST is primarily designed around. It's looking at achievement of universal health coverage, which is target 3.8 of SDG 3. And it's also looking at several other interrelated SDGs, looking at no poverty, zero hunger, quality education, gender equality, clean water and sanitation, definitely, affordable and clean energy, decent work and economic growth, sustainable cities and communities, climate action, and also life below water. They're talking about also the sanitation of the water, as well as the cleanliness of the environment in general. So there are interrelated SDGs as well that really impact SDG 3 as well as the livelihood of populations. So in going back to the Astana Declaration, this was a declaration that was sort of a re-declaration that was held in October 2018 in Astana, Kazakhstan. And they then identified just last year that PHC, primary health care, is the most inclusive, effective, and efficient approach to enhance people's physical and mental well-being. And they settled upon the idea that the cornerstone of sustainable health systems for UHC and health-related SDGs is PHC, is primary health care. So going through this equity-based approach, this might look very familiar, though slightly different. First of all, this is a football game that they're having. It's not baseball. But here, I think what they wanted to try and show, and what Dr. Rudan pointed out, is that if you started out on equal footing with different countries, let's say, you have totally different starting points. And if you used an approach that was equal or using equality, you'd have differences in viewing the game or in accessing health services, if we use that analogy. So an equitable approach is looking at sort of tailoring your strategies to your populations and ensuring that you're addressing inequity and ensuring equitable access. So delving into those principles, EQUIST was a tool that was developed and was highlighted by Dr. Rudan just previous to this. So EQUIST is a web-based equity tool, and it's developed by UNICEF. The online version is developed in partnership with the Community Systems Foundation. Also, they had an Excel-based version. And it's received funding mainly from the Bill and Melinda Gates Foundation. And EQUIST is an open source web-based tool used for strategic planning, and it's for prioritization for its health policy program makers to help guide them in terms of understanding a whole overview of their health system, as well as where the main issues lie, and conducting a bottleneck analysis subnationally to understand within populations where the worst off are, where the most vulnerable are, and how to reduce these inequities between the worst off populations and the better off. And these can be looked at through wealth quintiles, as was pointed out, or in terms of residents, in terms of populations by residents, and urban and rural populations, as well as other characteristics that we can take a look at further on. And EQUIST can be used at any level of the health system based on the data availability and what sources are being used. The other thing about EQUIST is it's flexible with the source being used. If you're using household data, if you're using routine data, as has most recently been highlighted in Ghana, where they had used their DHIS2 system, and we can take a look at that as a country example on the tool itself, and how the districts were captured, and how you get a lot more insight. And that's one major big point I wanted to make, is that if you're looking at population data, if you're looking at regions within a country, they may mask the data below. They may mask the data in the district level due to, let's say, the best example I can give is Ghana. For immunization, they had 90% coverage of North District in terms of DPT3 coverage. However, if you delve further down, even though the region says 90%, and you look at the districts, only half are 90% or above, the other half are below, even going down to 50% coverage. So it's important to look at the subnational levels in these areas. So what EQUIST uses is a 7-step approach, and this follows UNICEF's health systems strengthening approach. It's their 7 steps, and it mainly starts from identifying your priority population, so where the worst off are, and how to reach these populations. So this looks at data on their mortality in terms of coverage of essential health services, if they're able to access these. Then step 2 looks at, among these vulnerable populations, what are the main causes of mortality, or even in general in the entire country, what are the main causes of mortality, and to compare and contrast them with different population groups and look at morbidity as well as malnutrition. So you have your mortality as well as your morbidity in general. Step 3 then is looking at their priority interventions to address these causes of mortality and morbidity. So looking specifically at these populations, looking at coverage of these essential health interventions, and are those levels low? Is there a direct correlation between intervention coverage and mortality, morbidity? That's one important point to make. And so once the interventions have been selected that let's say a health policy planner wants to implement in country, they'll look at what are the bottlenecks of implementation of these interventions. So what is preventing effective implementation of these interventions in country? And for this, what you really need to do is you need to delve down deep into the situation within a particular province, within a particular district, looking at what are the local contextual issues that have to be overcome in order to ensure that your interventions are successfully being implemented. And then what's done after that is you identify the root causes of these bottlenecks, and then identify cost-effective solutions to addressing these bottlenecks, which are called bottleneck reduction strategies. So it's looking at very contextual strategies as well, and looking at, through their evidence bases, looking at effect sizes that these strategies have in reducing these bottlenecks and ensuring your interventions are effectively implemented. And then further, steps 6 and 7, we've sort of combined into one step onto EQUIST, is to look at the results. So what EQUIST has running at the back end is a tool called the LiveSave tool list, developed by Johns Hopkins University, which is a modeling tool. And what they use this for is to look at through changes and model through changes in coverage of health interventions, and taking into account the characteristics of a population, how many deaths could be averted, and how, or you can look at it as in terms of how the mortality rate could be reduced as well. And it's mainly for population groups among under 5s, among newborns, and as well as mothers as well. And more recently on EQUIST, the LIST team, LiveSave tool, have sort of developed a modeling for malnutrition as well. So looking at stunting, wasting, and maternal anemia, how many of each of these cases could be averted through nutrition interventions as well. So that's another output, a newer output that's been developed recently. And they've published this in their Journal of Nutrition quite recently, I think earlier this year or late last year, 2018. So moving on. This is sort of a diagram that shows, in terms of the flexibility of EQUIST, what types of data sources or where the tool can draw data from. So it can take data from a variety of sources. So primarily what's being used is DHS and MICS, the demographic health surveys, and the multiple indicator cluster surveys. DHS is very widely used amongst many countries, and so is MICS as household surveys that give you, through sample sizes, what the situational overview would be of a country, and looking at specific mortality rates and looking at general overall household characteristics. The other sort of sources the tool draws from is IGME, the UN Interagency Group on Mortality Estimates, which give a more recent estimate of what mortality is compared to what's published in the DHS or MICS, because the DHS and the MICS have a 5 to 10 year lag period. So when they do planning for coverage of health interventions and targeting mortality, they want to use the most recent estimate. So we tend to use IGME as well. We capture both sets of data on EQUIST, so you can compare and contrast as well. But just so the most recent estimate is used for planning purposes. Also, CHIRG data is used. The Child Health Epidemiological Reference Group has the causes of under 5 and newborn mortality as well, which they provide data for. And further than that, the tool as well, the outputs from the tool as a platform itself can be used alongside other tools. One such tool is health sector costing called the One Health tool. I'm not sure if anyone is familiar with One Health, but it's a very robust costing tool which allows for a country to enter very detailed costing information, and it gives very specific costing estimates in terms of implementation of strategies and interventions. And let's see, here is the main dashboard of EQUIST. Just to point out a few key elements. We'll be going through this when you have your on-screen demonstration. They have just mainly the title at the top, and then you have a scale in terms of what we're looking at here is Ghana, and it's under 5 mortality for Ghana, and this is by region. So here you can sort of get an overview in terms of what mortality looks like in the country. If you hover your mouse over, you'll also get a few more detailed information. You can look at the information by the indicator's name as well as the under 5 mortality rate in this case. And you can also select number if you wanted to see a total number of deaths breakdown. So for example, if you were, and we'll see this as we go on the on-screen demonstration, if you even take a look at Greater Accra region, as well as Ashanti, these two areas have the highest two densely populated cities and have the highest total number of under 5 deaths. So you'll be getting a different picture in terms of darkness of these shades compared to the under 5 mortality rate that you're seeing. So even though it's a higher number of deaths, that's because of the population that's residing in those areas. So that's one important element that health policy planners have to take in mind. Do they want to address under 5 mortality rate, or they want to address total number of deaths? And if they're looking at a short-term plan or a long-term plan, this changes drastically from country based on their decisions on what they consider to be the highest priority populations to focus on. And then at the bottom of the image, you'll have a source from where the data is coming from. If you click on the top left-hand side, it's just showing or hiding the menu. And to access the health data, so first you'll see here this analysis of submenu highlights mainly the indicators you can look at. So it could be demographic data, it could be epidemiologic data, even the mortality rates, and it's looking at causes of mortality as well. They have another submenu for interventions as well. So if you want to see intervention coverage, you can select those as well, and I'll get into how that's organized. The frontier analysis is something that's done by list. So what it does is it shows you is potential. So there are two types of frontiers. There's the equity frontier and the operational frontier. What the equity frontier looks at is if you achieve the same levels of coverage as the better off population. So what better off population could mean, it depends on how the country wants to define it. It could mean the richest quintile, for example. If they achieve the same levels of coverage as the wealthiest quintile, how many deaths could be averted among under 5s or among mothers as well as among newborns as well. So it sort of gives you, this is what sort of impact you can take a look at. And this is displayed by quintiles, so you can see how the poor quintiles compare to the richest one in terms of if they achieve the same levels of coverage, how many deaths could be averted. And it can look at the different regions as well. So looking at let's say northern Ghana compared to Greater Accra, Ghana. Northern is more spread out, has fewer health facilities, has higher mortality in general, whereas Greater Accra has less mortality in general and is more condensely packed and has all this access that Northern doesn't have, and is less remote populations and less poor populations. Okay, one important feature that you can play around and take a look at is this trends analysis. So in terms of regions here, as we're showing from Ghana 2008, which was a DHS survey, Ghana 2011, which is a mix survey, and Ghana 2014, which is a DHS 2014 survey, you can sort of look at trends in the data. What we normally noticed, and what we always have to put a disclaimer about, is that different sources may have a roller coaster effect with mortality, where you can see it looks like northern Ghana has dropped, but then has increased from 2011 to 2014, but it's may not be the case, and it's definitely not the case, because when you look at the source being used, Mixed 2011, they use a different methodology for their estimates for mortality. So it's that's important to keep in mind. So what we normally do is compare different data sets from the same source mainly. That's what we tend to do, or using the same methodology in general. So that's something we have to keep in mind about. And this was just to highlight to you that this may be the case where you have a roller coaster effect with several indicators that you see. In terms of the equity frontier, I'm just highlighting that here as well. So this is going to show you basically how many deaths could be averted by cause among under 5s and newborns if they receive the same levels of coverage as the better off. So this example here, this country example is Iraq. So it's looking at Iraq 2018 data and how you can expect, where you can expect the highest rates of mortality to be averted compared if you receive the same levels of coverage as the better off populations. So it's a sort of where maybe more investment should be made in terms of population group, and it's sort of a guide to help health policy planners organize their or allocate their resources in general. And you can actually also click away several of these causes. So here at the top we have neonatal mortality causes. So if you clicked on each of these bubbles, it would sort of disappear from the bar chart, and you can just keep under 5 mortality, just and maybe look at just one age grouping here. Okay, and then looking at EQUIST and its approach, we're looking at the 7-step approach, so how it's shown on EQUIST. So first you're looking at identifying the underserved groups, which I can move back to, yes, and then looking at the main causes of mortality. So what we have here is a tree diagram for neonatal mortality. So when you go through your scenario analysis on EQUIST, the main goal of this module is to generate your own scenario in which you go through EQUIST 7-step process from beginning to end, and at the end generate results. So generate a modeled result in terms of how many deaths you could avert, how many causes of malnutrition you could avert, and relevant costs. So costs in terms of in cost effectiveness, in terms of where costs should be allocated and how they should be allocated for specific strategies, as well as cost effectiveness. So deaths averted per US $1 million spent is an example. So here what you're having in terms of this tree diagram is where what the highest causes of mortality are among a specific population. So here it's highlighting that prematurity, so among neonatal mortality, prematurity is amongst the highest, along with sepsis and asphyxia, and less so with congenital anomalies and tetanus. The tool then also looks at specifically what the leading causes of death are for under 5 years as well as for mothers. So neonates also fall under the under 5 years of age, considered as part of that group. So you will see neonatal causes there, but you can choose to focus on post-neonatal causes of mortality as well. There's a sub-menu for that you can select. And in terms of the interventions now to implement to address these causes of mortality, how they're organized on EQUIST are by 3 service delivery modes: by family care practices, preventive services, and curative services. So family care practices look at what's usually done in the household by the mothers. So it's looking at also wash interventions, water and sanitation, hygiene, hand washing with soap before preparation of meals, and access to clean and safe water. And environmental safety and ITNs looks at addressing malaria, looking at whether bed nets are being used, mosquito nets, ITNs, and ownership of them. And then there is neonatal infant feeding and care, which is looking at infant and young child feeding, and it's looking at your breastfeeding practices, continued breastfeeding, early and exclusive breastfeeding, all those interventions. Then we're looking at, under preventive services, these are what can be done to prevent illness in general. And there's family planning, antenatal care, whether mothers are going in to access this care in health facilities and receiving appropriate care, how many visits they're getting, and what bottlenecks may exist from preventing them from receiving quality care, whether it's blood pressure taken or urine sample taken, etc. For immunization, we're looking at, it's very straightforward, just the immunizations coverage, and looking at in terms of what they're receiving in terms of DPT, measles, all different vaccinations, BCG. And curative services are done usually mainly in the health facility, and it's for treatment, looking at IMNCI is what we call integrated management of neonatal and childhood illness. And what that looks at is treatment of diarrhea through antibiotics or ORS, oral rehydration solution, or zinc. Or it could be antibiotics for pneumonia or therapeutic feeding as well. Under skilled birth attendants, this is also an important intervention. We're trying to see here whether deliveries are being held within health facilities, first of all, and by skilled birth attendants. So we're trying to identify also here if there are issues and there is lower coverage of these interventions, what the reason is why populations are not accessing health facilities for delivery. Then we're also looking at emergency obstetric and newborn care under curative services, EMONC in short. And here we're looking at complications at birth and how to treat those complications. So whether it be neonatal resuscitation for asphyxia and a host of other complications at birth. Moving on from that, we have also as well here in terms of coverage now, looking at, this is for preventive services, looking at what the coverage rates are of these interventions for the same population. So moving on from, we identified the main causes of mortality, and now we're moving on to how to address these main causes of mortality and morbidity. So in step 4 of EQUIST, this is the bottleneck analysis that we're starting. What EQUIST has used is what's known as the determinant approach, which is based off the Tanahashi model. The Tanahashi model looks at the specific determinants leading to gaps in terms of effective coverage. So what your effective coverage is the full quality of your intervention you're looking at. So what it takes into account is availability of commodities. So if I can give the example of immunization, if we're looking at, let's say, measles immunization, it's whether there's low coverage or high coverage and identifying why. Human resources, are there enough health personnel, health service members or teams that can deliver this health service or not? Why is that lacking? Accessibility, how far are populations from these health facilities where they can access these health services, and are there barriers in place? Are there maybe poor road conditions or hills or lakes? If you're speaking about antenatal care, can a mother walk to the health facility? She's pregnant, so it's very hard for her to sort of access these health facilities. Something that's not covered in the Tanahashi approach, that's covered as a separate determinant in under the determinant approach, is financial affordability, and that's looking at direct costs. Are there just barriers in terms of paying for the health services, or are there barriers through indirect costs of paying for transportation to access the health services as well? So there are multiple factors one has to keep in mind in the specific contexts where we're dealing with. In terms of initial utilization, once you've gone through the supply and demand bottlenecks, you're looking at these core bottlenecks, which have to follow a cascade. What this means is initial utilization has to be the highest among the three because it's looking at our population. So if I give the case for antenatal care, the mothers, are they getting at least one visit at a health facility for antenatal care? So it's looking at that initial access to care. That's mainly what this determinant is looking at. And usually an indicator that's assigned for it is, like, for example, antenatal care ANC1, at least one visit to an antenatal care facility. For adequate coverage, what we're looking at is continuity of care. So once they've had the initial visit, are they coming back for repeat visits? So this indicator, for example, could be 4 or more antenatal care visits, whether the mother's continuously coming back for care. And effective coverage is now looking at the quality of the care and the impact of the care. So this is what we're mainly trying to alter and try to improve as much as possible by addressing these other determinants to ensure that you get the maximum quality of care. And this is looking at the health intervention itself. It could be, is a mother also getting her blood pressure taken? Is she getting a urine sample taken? Is she getting the full quality of care that is necessary for her well-being and her child's well-being? So I think this is the main structure of what the bottleneck analysis is within EQUIST. And so you can see the worse off or the lower these other determinants go in terms of the indicators, the higher the gap is between the quality of care and the entire population that's accessing this care, or in this case, this entire population that's accessing this care. So looking at the structure of the Tanahashi model, or the determinant approach as it's called on EQUIST, is like this. It's similar, except as you can see, it's a reverse. So this is starting from effective coverage to the other supply and demand determinants. Here we're looking up at the supply and demand determinants, and then looking at initial utilization, adequate coverage and effective coverage, and in terms of their interventions coverage as well, indicator coverage as well, and sort of highlights the bottleneck itself. You're also given a small traffic light system. It's not shown here, but you'll be able to see it on the site itself, which shows you from the system what the system identifies as severe bottleneck or less severe bottleneck, and it's up to the user to decide which determinants they wish to address specifically for a specific intervention. In terms of what you'll see down here, a little table for enabling environment. So this has not been fully captured on EQUIST as something that could contribute to an output. What it's just there is for extra detail for the analysis. I think at this stage, the enabling environment is just there that one can highlight in terms of, and point out that, in terms of legislation, policy, and social norms, budget expenditure, and management coordination, what the levels of those are. But in terms of an output on EQUIST, that hasn't been developed at this stage. So moving on to, so as you can see here, step 4. We're looking at here now the specific strategies in the next step. So looking at how to address these bottlenecks. So the way it's shown on EQUIST specifically is you're giving these orange ranges, which come from the global evidence base. So an evidence review was conducted by Avenir Health, ABT, Johns Hopkins was involved, to identify what the impact of health interventions were globally. And they looked specifically at strategies, bottleneck reduction strategies in overcoming bottlenecks. So they looked at the specific effect sizes, what types of ranges we're looking at. And so one can go in and they can adjust these sliders here in terms of these health strategies to identify either within this range if they want to follow the global evidence, or if they have their own global evidence, they can overextend beyond these ranges to give an idea of what the contextual effect size that they expect from these strategies to be. On the left-hand side, you'll see another traffic light system as well, which allows the user to select their bottleneck reduction strategies based on the relevance of the strategy to the intervention that they're looking at. And they can also access, on the right-hand side, it's not shown, but they show different sources of evidence, so you can actually access the evidence base as well to take a look at. One further thing, one other feature that you can sort of make specifically custom to your analysis is if you're dealing with specific bottleneck reduction strategies, one can enter this here, put in their own effect size, and can alter the details of this specific health strategy and how that could contribute to improvements in coverage of interventions. I'll also, let's see, I'll point it here. Okay, so in terms of steps 6 and 7 now, what we're looking at here is the impact and cost. So in terms of cost, you have a breakdown of the strategies that we just saw and how much spending is to be allocated for each of these services. So here you can get a sort of breakdown. It's important to highlight that EQUIST doesn't give a specific costing. This is how much all these interventions will cost for these populations. That's not what EQUIST does. It looks at marginal costs and marginal budgeting. So starting from baseline 0 and implementation of these interventions, what you expect in terms of costs in general. What you can see in the middle here, this middle chart is looking at cost effectiveness. So in terms of how many deaths can be averted in your analysis per US $1 million spent, and then the cost per capita of a specific scenario as well. You can get a specific unit cost per person accessing these services. Right. So then moving on, we also have, with selected strategies, you can make this comparison in terms of how many deaths one can avert from one scenario to the next, and also number of lives saved per $1 million US as well, one compared to the next. So if we're looking at scenario 1, we're looking at how many lives were saved total here. It's close to 9,000 deaths averted by different causes. And then scenario 2, 4,500 deaths averted. And then looking at the cost effectiveness. So for every US $1 million you're spending in scenario 1, you're preventing 500 deaths, under 5, let's say. And in scenario 2, for every $1 million you're spending, you're only averting 200. So for comparison's sake, this is a very concrete, standard example, but normally what you'll have is you may have higher impact in one and slightly lesser impact in the second scenario, but you may have much higher cost effectiveness in the second scenario and a lesser cost effective scenario for scenario 1. So what you can do is, through this scenario comparison, you can either create a third scenario, or you can adjust one of the scenarios to ensure that you maximize your cost effectiveness and impact of interventions.
So are these two related? Does that mean that if you're sort of saving 500 lives per $1 million in the same scenario one, you would have to spend 18 million to save those 9,000 lives?
In scenario 2, based on their selections made, so this is assuming this is the same population we're looking at, then it's based on their selections made and based on which health strategies that they're implementing. If they choose health strategies with low effect sizes that aren't as impactful, then they'd have to go in and readjust and select different strategies, or try to see maybe different population groups where these strategies can be more impactful and more cost effective. So for health policy program makers, this is important in the sense of should we focus on populations where we have a higher under 5 mortality rate but a lower total number of deaths, or should we focus on populations which are the opposite, which have a higher total number of deaths but a lower under 5 mortality rate? So this is the scale that health policy program makers have to try and balance, and to find really which populations that they should allocate resources to most effectively.
And they ought to know the effectiveness of their strategies beforehand.
Absolutely, yeah. So that's the thing also with EQUIST. That's one key knowledge that health policy program makers have to contribute is otherwise there will be default effect sizes provided from the global evidence base, but it's up to health policy program makers within their own local context to identify these are the proper effect sizes that fit this specific context compared to the global effect sizes. Yeah, so this was just highlighting that. So that's the short presentation. That's over. So we'll move on to the narrowing the gaps very quickly. I just want to highlight this is the case for equity that was made. It delves quite a lot into the details that Professor Rudan just mentioned in the previous presentation, but I'll quickly go through narrowing the gaps. It's in a piece of work that was the original Narrowing the Gaps paper was published from 2010 to 2012. And this was published under the previous executive director of UNICEF, Mr. Tony Lake, which had a hypothesis and made the case for addressing equity to address mortality and improve health and livelihood globally. With the same level of investment, disproportionately higher effects are possible by prioritizing the poorest and most marginalized populations. So highest deaths averted per $1 million invested. So they sort of challenged, and this goes very much in line with what Dr. Rudan had mentioned, that even though it's more expensive to access the poor populations, they're in more remote communities, they're less infrastructure, the road conditions are bad, even transportation of commodities is going to be more expensive in terms of the condition and breakdown of the vehicle, maybe the refrigeration for the vaccinations and during transport goes bad, and they lose vaccinations. Those sort of things can really impact the poorest populations. So the hypothesis was, despite these higher costs, you'll be able to, through investment in the worse off, achieve higher number of deaths averted. And this paper was a prospective study. So looking forward, this is what their prediction was based on the data available at the time. So the study objectives completely focused on two groups, the poor and the non-poor, what they deemed. It's looking at coverage gaps of interventions and looking at if the coverage gaps, so in terms of the higher coverage among the usually among the non-poor and the poor populations, have they narrowed in recent years or not, and why? And what is the projected impact on under 5 mortality? Again, we're looking at, have the gaps narrowed more throughout the years from the poor to the what they call the non-poor, the wealthier populations. And the third question is, investing the poor more cost effective than investing in the non-poor? So they set out to try and answer these three objectives. So the main sources of data that were used are the DHS and mixed household surveys and other globally validated data and modeling as well to contribute to the analysis. And they had conducted an external expert review of the methods and financing, and this was through another number of organizations, even from Johns Hopkins and Avenir ABT again, and WHO, several other NGOs were involved in the external review. And then there was a sensitivity analysis conducted to, in fact, test the analysis and ensure that the analysis was robust in its findings. And the So this is the second paper, was published in mid-2017. So whereas the first paper was prospective and looking and made this hypothesis that in general investing in the poor off would would be more cost effective. The 2017 paper is a retrospective paper, so looking again 7 years in advance. What has happened? Have the gaps reduced from looking from several different time frames? What has the data shown? So the time frames we're looking at are 2003 to 2010 as the first trends, and 2010 to 2016 as the second. The median baseline year is 2006, and the median endline year is 2013. And comparing the surveys of 51 countries globally, which had data availability on DHS or mix, to provide to this analysis. And what was important, and it was in terms of these specific 51 countries, was that 80% of global under 5 deaths occurred within these 51 countries. So in terms of which 51 we're looking at, and we're including the analysis based on data availability, it's mostly, as you can see, through Western and Sub-Saharan Africa as well, where most of these countries' data came from, and also Asia as well. Asia and the Pacific, large contributors to this data. In terms of poverty, what was used for the analysis was the World Bank's poverty index. So it's their poverty parity index, and which they used $3.10 US a day to classify a population's quintiles as poor or non-poor. So this is an important point that Dr. Rudan made also, is that if you're looking at quintiles, it may not be very comparable from one country to the next. And this can be shown from these two examples. Chad. So their poverty headcount ratio is 85%, which means that more than 80%, or their poorest 4 quintiles, are below the poverty line compared to 1 quintile above. So approximately close to 15% is considered above the poverty line, which you can compare to Vietnam as having only 1 wealth quintile below the poverty line, and the richer quintiles above the poverty line. So with this specific type of case in mind, we had to recategorize the countries and take into account the different country contexts. So we had to classify countries as type A countries if they had 4 quintiles above the poverty line and only 1 quintile, below the poverty line and 1 quintile above. Type B1 and B2 countries, which are countries that had either 2 quintiles below and 3 quintiles above the poverty line, or 3 quintiles below and 2 quintiles above the poverty line. And then type C countries, which were 4 wealth quintiles above the poverty line and 1 wealth quintile below the poverty line. So, yes.
So
yes.
that 3.18 or whatever the number was for poverty line, is that
Yes.
per person or per family? What is the?
This was per person. The index.
Access to that much money per day.
Per day, yeah.
And so from that point of view, this sort of way, the 85% population is being poor.
Is considered poor based on the population. So taking into account with a definition of a quintile being 20% of the population, allocating that specific poverty index, the poverty parity index, to those quintiles specifically.
And that counts children and adults as well, equally in that 3.1.
Yes. Right. So in terms of answering the first question, have coverage gaps between the poor and non-poor groups changed in recent years? Specific tracer indicators were used, covering different packages, and many of these you can see are similar to what are on EQUIST for their structure of interventions. So looking at environmental health, looking at the ITNs, are children under 5 sleeping under ITNs, infant young child feeding and care, what is the rate of early initiation of breastfeeding, antenatal care, are mothers receiving continual care, so 4 more visits, and immunization, are children fully vaccinated, that means have they received all 8 basic vaccinations. Delivery of care, are children or births attended by a skilled birth attendant, or in curative care for sick children. It's looking at rate of care seeking for children with diarrhea, fever, or pneumonia. This was more of a composite indicator looking at receiving care within health facilities of children under 5. So question 2 was, what is the projected impact of these changes on under 5 mortality? So 35 high impact interventions were covered for the poor and non-poor groups per country. And LIST, LifeSave tool, was used to estimate how changes in intervention coverage translated into lives saved, which is the basis for LIST. And this is, the thing about LIST is it can only be done nationally. So that's something to keep in mind. So this analysis was a national analysis, not a subnational analysis. For costing, is investing in the poor more cost effective than investing in the non-poor? Only half of the countries, less than half of the countries could be taken, a subset of 24 countries among the 51 for this analysis because of data availability through DHS. And the costs being looked at, again, are infrastructure, human resources, medical commodities, and then information, transport, household costs, and additional costs of reaching the more remote, vulnerable children in hard-to-reach areas. So reviewing the results, what was found is that coverage of high-impact interventions increased more rapidly among the poor than the non-poor among the baseline year to the end-line year. So you can see among the poorer populations that the gap had closed more than among the richer. So I don't see it here unless, yeah, I think the light blue is the richer, or is the non-poor group, what they labeled. And the poor group is showing a 23% to 15% gap with the less than non-poor. And in terms of being cost effective, this is something also that Dr. Rudon pointed out. In terms of spending, let's say, US $1 million in one group to the other, the poor group, they're showing that spending US $1 million on average saved 166 lives among the poor versus 92 deaths among the non-poor, which is 1.8 times more lives saved among the poor versus the non-poor. And it's showing it's, in terms of cost, that was the case for cost effectiveness and investing in the underreached and underserved populations compared to the better off. So, okay, that was it also for the Narrowing the Gaps presentation. And I think we can now go hands-on with the tool as well. If there's any questions, feel free, maybe if you can take a slight pause for any questions. Thank you.